Welcome to Washington Hospital Today, dedicated to informing residents about healthcare topics and issues. Through programs featuring community forums and free health and wellness classes, our goal is to empower community members with the information needed to make informed health decisions. Washington Hospital has been providing healthcare to the residents of the Washington Township Healthcare District for the past 60 years.
Hello, welcome to today's presentation, Genetic Testing for Breast Cancer Risk, presented by Dr. Bogdan Eftimie, hematologist, oncologist, and medical director with the UCSF Washington Cancer Center. Dr. Eftimie is a UCSF hematologist-oncologist who cares for patients with a wide range of solid tumors, including those of the lung, breast, colon, prostate, skin, and most blood cancers. He also provides care for patients with non-cancerous blood conditions, such as anemia and problems with bleeding or clotting. Dr. Eftimie is a clinical associate at UCSF and serves as medical director of UCSF and Washington Hospital Healthcare System's Joint Medical Oncology Service. Eftimie earned his medical degree from Loma Linda University, where he also completed a residency in internal medicine and served as chief resident at the Veterans Affairs Loma Linda Healthcare System. He completed a fellowship in hematology oncology at the University of California, San Diego. He is a member of the American Society of Hematology and American Society of Clinical Oncology. Please welcome Dr. Eftimie.
Hello, everyone. Good afternoon, and thank you for joining us on this wonderful fall day. I'd like to extend my thanks to Washington Healthcare System for asking me to talk about this very important topic. I also would like to thank the production team over here who's behind the screen, and you don't get to see them, but they make everything happen. Today, I would like to talk about BRCA1 and BRCA2 mutations and what is the implication for breast cancer. So a little bit of cancer genetics. We can't really talk about genetic testing without understanding a little bit what exactly we're talking about. So at the root of it, all cancers develop from defects in certain genes. These are called pathogenic or likely pathogenic variants, P or LP as an abbreviation, of certain genes. These genes in general are involved in regulation of cell growth and DNA repair. Not all of these defective genes are inherited from our parents, and this is an important concept that I like to explore a little bit further. So, how do we get the genes, and what exactly are the genes? The DNA is a structure in almost all cells, which is the building block for genes. And I say almost all cells because, for example, platelets or red blood cells, they actually do not have any nucleus in them, though they will have mitochondria, and you can actually have some genes as part of the mitochondria. But if I may show you here if you can see my cursor on the bottom of this representation, you can actually see the DNA backbone and a series of nucleotides, usually they're called bases, a series that can span anywhere between a few hundreds to a few thousands of these nucleotides actually encode a gene. Well, this DNA, this physical representation of a gene, actually spirals around, you don't see it in this picture, the spirals around this protein called histones, and then those histones, they get bigger and bigger, and they actually create a chromosome. So genes are the instructions that tell each cell how to grow, develop, and work. It tells them how often each cell grows, how often it divides to make new cells, how long it lives. Multiple genes are arranged in larger structures called chromosomes. And this over here on the left side is an actual representation of the 23 pairs of chromosomes that we have in our bodies. So chromosomes, you can think of them as genes as being photographs in the photo album. The photo album is the chromosome. So if a gene is a picture, then a multiple of genes together, they're part of a photo album. Most people have 46 chromosomes in total, 23 pairs, and each chromosome of the pair comes from the mother and father respectively. And the reason I wanted to say this is because inherited genes, they can come either from mother or father, or rarely they can come from both. But for example, in most patients, they only get one gene from each parent. And if that gene is mutated, but the other gene that they get from the father or mother respectively is not mutated, then patients may end up being okay. They may never have any problems. So how do genes actually tell your cells what to do? And this is actually a very good representation from the cancer.gov website. But really quickly, you can think of it as the DNA will be transcribed by another protein to form an RNA, which is the template by which the protein will be formed. So basically, the DNA is the information, and the RNA is the hardware that creates the protein. And essentially, it's the protein that tells the cell what to do. And actually, all of our human body cannot function if we do not have proteins. Proteins are extremely important of telling cells what to do, how to grow, when to grow, how much to grow, and eventually when to die. Cancer starts when one or more genes in the cell change or mutate, and what this leads to is that the gene itself, instead of making a normal protein, it can make an abnormal protein, or it can make no protein at all. And as a consequence, the particular function of that protein is absent, and that potentially could lead to a cancer formation. So this can lead to cells multiplying out of control and potentially cause cancer. This is probably the most important slide of the beginning of this lecture, which is what are the two main type of mutations? And this is where most people actually get a little bit confused, and I want to dispel this confusion. So you can have either somatic mutations or you can have germline mutations. And really quickly, I'm going to start from the germline mutation here on the left side, the pink side of this representation. And here you actually have the sperm and you have the egg, and you can see that the sperm is actually orange. Once the sperm and the egg fuse together and they create the embryo, you see that the whole embryo is orange, and eventually the whole body is orange. What that represents is the fact that the gene that was present in the sperm eventually became part of every single cell of this human, and it will persist in this human for the rest of their lives. Not only that, but, I do apologize, not only that, but the sperm of this male, half of the sperm will have this gene. So this is what we call inherited genes or germline mutations. And the topic for today's discussion deals with these inherited mutations, BRCA1 and BRCA2. Contrasting that is actually a somatic mutation. In a somatic mutation, you do not inherit it. So for example, you can see the sperm over here is blue and the egg is green. They create an embryo that is yellow. And you could actually get a mutation in the embryo. In one of the cells, they acquire a mutation for whatever reason. That mutation can stay there, but only in those cells. And eventually those cells may end up growing to have cancer. But notice how the rest of the body does not have that mutation. That means that this male, which I hope it's a male looking at this representation, cannot pass this mutation to the sperm. It's not a germline mutation, it's a somatic mutation. So somatic mutations can occur in any cell of the body except those found in eggs or sperm, and they cannot be inherited or passed on to offspring. Germline mutations, on the other hand, are only found in cells of egg and sperm. So the somatic mutation, how do we get them? This is actually a representation. So I have my cursor here looking at the green DNA, and it's a representation of types of damages that can occur to the DNA and essentially genes that can lead to cancer. So you can have exogenous sources such as ultraviolet light or radiation or other chemicals. It used to be that people who worked in the leather industry back in the late 1800s, they used to have aniline dyes, and that aniline dye actually interfered with certain cells in the bladder, and they would have very high rates of bladder cancer. You can have endogenous sources, meaning sources that are inside the body, and this can occur either by alkylation, so actually chemotherapies that we give, for example, for breast cancer, down the line, 20 to 30 years down the line, could lead to a certain DNA damage that can happen. Or you can actually have a DNA damage that occurs because the DNA is not replicating correctly. You can have a misreplication, you can have an abnormal chromosomal segregation, meaning when a cell divides in two, each chromosome actually splits in half. Half goes to one cell, the other half goes to the other cell. Sometimes the split doesn't happen exactly in the middle, and you can have one cell that has 51.5% of the DNA, and the other cell will have 48.5% of the DNA. Essentially, one of the cells is missing a certain part of a gene. That can lead to a mutation that potentially could lead to cancer. You can actually have problems with pathways in the cells that get affected. Diet sometimes, smoking for sure can do it, stress, the lack of sleep. All of this can actually affect some of these pathways in the cells that eventually could potentially lead to early aging, which can then lead to cancer. So somatic mutation, they happen on their own during your lifetime, so you do not inherit them. You are not born with them, and your offspring will not inherit them. They are the most common cause of cancer. They are called sporadic mutations and are only present in cancer cells, not in any other cell in the body. Risk factors, as we talked about, include tobacco use, ultraviolet radiation, as well as viruses and aging. I'm going to skip this really quickly. The germline mutations, they're also called pathogenic variants. They come from your parents. So again, this is a representation of the pink part of the graph over here. The embryo will lead to the adult human to have the mutation in his or her sperm. The person can now pass this mutation to their offspring. This type of cancer is called inherited cancer, and about 5 to 20% of all cancer starts from a mutation passed on by the parent. So family studies show that certain cancers have an increased risk of several forms of certain mutations have an increased risk of forms of cancer in the first and second degree relatives. This is the result of one or more pathogenic or likely pathogenic germline cells. These are classified as hereditary or familial cancers. These syndromes arise from germline variants. So again, these are not somatic mutations, these are germline mutations. They are not within the sex-linked genes, meaning that they do not come from the female or the male chromosome. So that's why you can get these genes both in females and males. These genes can be inherited from either parent. They are associated with breast cancer at an early age or other cancers as well. Can exhibit an autosomal dominant inheritance, and offspring of affected individuals have a 50% chance of inheriting the variant. And here in this graph, the only thing that I want to show you is that here on the left side, you see 30% all the way down to 0%. And if you look in aggregate, in more than a few thousand patients with breast cancer, when they were tested for the BRCA1 or BRCA gene, about 17% in aggregate actually had the BRCA1 or 2 mutated. So what this tells you is that out of 100 patients with cancer, with breast cancer, as little as about 2.5% of them and as much as about 17% of them could actually have the cancer come because of a genetic mutation that they inherited. The rest of those patients, anywhere between 98% on the high end and about 85% or 83% on the low end, they actually get their mutations from other reasons. The somatic mutations that we were talking about. Today, we're only talking about the inherited genes, which are the BRCA1 or 2. So, Tumor suppressor genes are basically genes that protect against cancer cells, and I'm particularly talking about genes right now that are involved in cancer production. They limit how much a tumor cell can grow, so these are the quote-unquote good type of genes. They basically protect you against cancer. You can have oncogenes, which are basically oncogenic mutations that can turn normal cells into cancer cells. And unlike tumor suppressor genes, oncogenes are not known to be passed down from parents or to their offspring. These are called sporadic mutations, and a somatic mutation can be an oncogene. You can also have a DNA repair gene, so they fix the mistakes that can happen during the DNA replication. And this is where the BRCA1 and BRCA2 genes come in, because they are called DNA repair genes, or also tumor suppressor genes. And this is actually a great cartoon from the National Cancer Institute. And here on the left side, you have a yellow car, and the green part is actually, it's an engine, and this is actually an oncogene. And here you have a parking brake that this is the suppressor, the tumor suppressor gene. As long as the parking brake is on, even if the engine is going, the car does not move. But if you have an active oncogene, meaning the engine is turned on, the car will slowly move forward and eventually get to this wall called cancer. But if you have no tumor suppressor gene or a DNA repair gene, then you have no brake. The oncogene makes the car go forward and eventually will lead to cancer. This is actually a fairly old style of looking at things. Right now we know that you can have not only 2 mutations, but you can have 3 or 4 mutations that eventually can lead to cancer. So BRCA1 and BRCA2, what do? Essentially, they are caretaker genes. What that means is that they ensure the genetic integrity that is not compromised by unscheduled loss, duplication, or rearrangement of the chromosomal DNA. Remember when I was talking to you earlier that when a cell divides, it cleaves itself in 2. Half of the genetic material goes to one cell, half goes to the other cell. If they're not equally split, that's when you get this unscheduled loss of chromosome or duplication of chromosomes. One cell gets 2 chromosomes, the other cell gets none. That's when mutations can happen. BRCA1 and BRCA2 genes are there to repair any of these problems. So you can see here in the middle that you can actually have a normal BRCA1 and BRCA2, and this is a cartoon showing you how DNA, how the DNA actually opens up in order for these proteins to actually copy the DNA material. But sometimes the right side of the DNA will break loose. Well, the BRCA1 or 2, including with this other gene called RAD51, they're there to repair this part of the DNA to prevent it from actually having abnormal genes produced. On the right side, you can actually see in patients with mutant BRCA1 and BRCA2, how the DNA doesn't repair. So you have this big star over here. It just shows you that this DNA eventually will lead to a new area where it actually can get glued, quote unquote glued, and now you have a new gene rather than the old one that might be mutated. So BRCA1 and 2, BRCA1 and 2, they lead to specific patterns of hereditary breast and ovarian cancer. But it's not the only complement of genes that deal with breast cancer. You can actually have a mutation in TP53 gene, which is a lot more rare than the BRCA1 and 2, that can also potentially lead to breast cancer. You can have Cowden syndrome that deals with a PTEN variation gene. You can have PALB2, which is also another gene involved with increased risk of breast cancer. But for the purposes of today's discussion, we're only going to talk about the BRCA1 and 2 related breast cancer risk. So for any woman out there who actually has a BRCA1 or BRCA2 mutation, the risk for that woman to develop a cancer within the next, between her 75th to 85th year is approximately 72%. So this is actually from a study looking at 9,800 unaffected patients with a known BRCA1 and 2 carrier, they showed that the cumulative risk of breast cancer by 80 years is 72% for the BRCA1 variant and 69% for the BRCA2 variant. More importantly, though, for a woman who has BRCA1 or BRCA2 and she has had the breast cancer and she has dealt with it, surgery, maybe chemotherapy, maybe anti-hormonal treatment, maybe radiation, so she's done with that. If she still has a contralateral breast, that left breast, let's say she had the breast cancer on the right side and she had a mastectomy on the right side, but she still has a left breast, that left breast will still have about a 40% chance of a brand new breast cancer within the first 20 years after the original cancer on the right side, and for a BRCA2 is approximately 26%. Interestingly, though, there's no clear evidence that BRCA1 or 2 associated breast cancers have a poorer prognosis. So it can be, some studies suggest that it might be a little bit worse. Other studies do not suggest it. The risk for other cancers also increases with BRCA2 mutation. So this is for ovarian cancer. By the age of 70, the BRCA1 patients will actually have a 48% chance of developing ovarian cancer, and BRCA2 will have a 20% chance, which actually are very high chances. There's also pancreatic cancer risk. It's approximately 3% for males and 2.5% for females. Contrast that with the general population. So the general population, the prevalence is about 0.2 to 0.3%. And again, remember the graph that I showed you, that the prevalence of BRCA1 and BRCA2 mutation in women with breast cancer is anywhere between 2.5 to about 17% in the United States. For all women and all men without known cancer, the prevalence, meaning the chance of having a BRCA1 mutation, is about 0.2 to 0.3%. Certain ethnic populations have a higher chance, so 2% of Ashkenazi Jewish descent people will actually have a BRCA1 and BRCA2 mutations called founder mutations. There are also populations in other countries, including Holland and Iceland and Norway. So really quickly, I just wanted to take you through what to do if you actually do have a BRCA1 or 2 mutation, or how do we know who to test? So this is actually the National Comprehensive Cancer Network. It's a collection of approximately, not a collection, but it's a cooperation between about 35 to 37 cancer centers in the United States, and they have specialists in every cancer field. So this is actually the guidelines dealing with what to do and whom to test. So this is the slide showing you who should get tested for BRCA1 and BRCA2 mutation. It's a little bit busy, but work with me here for a second. For any woman with breast cancer under the age of 50, she should get tested. Or any woman with breast cancer at any age if the following are met. If the treatment decision to treat with a PARP inhibitor is a newer medication that deals with patients with BRCA1 and BRCA2 mutations. And these PARP inhibitors, they're actually certain oral medications that can actually act specifically on these cells, and they have a very good effectiveness against the cancer and the treatment of the cancer. So if we think that a woman may benefit from a PARP inhibitor, she should get tested. If the woman has a triple negative breast cancer, meaning that the estrogen receptor is negative, progesterone receptor protein is negative, and HER2/neu protein is also negative. So this is called a triple negative breast cancer. Approximately 10 to 15% of all women get the triple negative, and it turns a prognosis. It's a worse type of a cancer. This also is associated with a higher rate of BRCA1 and BRCA2 mutations. Or if a woman has multiple primary breast cancers, so either she can have a breast cancer on the right side or the left side, or she actually has had one a couple of years ago and she has another one, or a lobular cancer, breast cancer, which is a type of breast cancer, or a family of gastric cancer. And if the woman has breast cancer and she has a relative who's a male with breast cancer, that is a first or second degree, then they should actually get tested for the BRCA1 mutation, or ancestry. So like we were saying earlier, Ashkenazi Jewish ancestry, or one of those known founder mutations like some of the families in Norway, Holland, and Iceland. At any age, if the family history includes more than one close blood relative with breast cancer who was young, so if her sister had breast cancer when she was 4 years old, she should get tested. If there was any male breast cancer in that first or second degree relative, if there's ovarian cancer in any of the first or second degree relative, if there's pancreatic cancer in a first degree relative, if there's prostate cancer that is metastatic or high risk prostate cancer, then that woman, regardless of the age, should get tested for the BRCA1 or 2 mutation. And if there are greater than 3 diagnoses of breast or prostate cancer on the same side of the family, regardless whether it's a first degree, second degree relatives. So again, for the BRCA1, the absolute risk for a woman, if she has the BRCA1 mutation, the absolute risk of developing a breast cancer by the age of 80 is approximately 60%. The management of this, we'll talk about it really quickly, is basically to treat the cancer and then to discuss whether or not a bilateral mastectomy and a salpingo-oophorectomy, meaning taking the ovaries and the fallopian tubes out, should be entertained. For male breast cancer with a BRCA1 mutation, the absolute risk is approximately 0.2 to 1.2%. In some cases, it's actually a little bit higher by the age of 70. What to do about it is a little bit murkier if you don't already have the prostate cancer. For a BRCA2, so again, these are women with a known BRCA2 mutation. There's no evidence of cancer right now. The absolute risk of developing a cancer would be greater than 60%. Again, what to do about it is, treat the cancer if you do have it, or if you don't have the cancer, actually do a bilateral mastectomy. For a male breast cancer, the risk of developing a prostate cancer is higher. It's about 1.8 to 7% by the age of 70. So, for a woman who has known BRCA1 or 2, what should we do about it? So, she should actually have breast awareness starting at the age of 18. What exactly does that mean? It means breast examinations, clinical breast exam every 6 to 12 months starting at the age of 25 years. The breast screening should start between the age of 27 and 29 with an annual breast MRI or mammogram, or a combination of both. By the time she reaches the age of 39, between 39 and 75 years, it should be annual mammogram and MRI, and greater than 75 years, it should be management per individual basis. And discuss the options for risk reduction mastectomy, which is something that any woman who has a known BRCA1 or 2 mutation should actually have a thorough discussion, not only with the oncologist, but primary care physician, as well as a plastic surgeon and a general surgeon that specializes in breast surgery. There is no specific age when that should be done. Remember, this is a prophylactic treatment. It's not a treatment for a breast cancer, but this is definitely something that should be discussed. For a male breast cancer for a male who has known BRCA1 or BRCA2 mutation and doesn't have any breast cancer, there should be a breast self-exam done starting at the age of about 30 to 35. There should be a clinical breast exam every 12 months starting at the age of 35, and consider an annual mammogram starting at the age of 35 or 40. Believe it or not, approximately 1% of all breast cancers in the United States are male breast cancers, which equate to about 2,000 to 2,500 new male breast cancers in the United States every year. If they have a BRCA1 variant, the lifetime risk is almost 7% of developing a breast cancer in a male. And I wanted to end with this slide because nowadays, we can get tested in many ways, but sometimes we come back with a genetic representation that may actually not be a BRCA1 or BRCA2, or they'll say variants of uncertain significance. And just because a patient actually has a genetic mutation that is called a variant of uncertain significance doesn't necessarily mean that this is actually a pathogenic gene. It doesn't necessarily mean that it will cause cancer. So in a recent study, when they looked at reclassification of variant of unknown significance, of uncertain significance, approximately 80 to 90% of those variant of uncertain significance, they were downgraded to benign or likely benign, meaning that after they withstood the test of time, so patients have been known to have variant of uncertain significance for the better part of the last 2.5 decades, and now we know that those genes do not lead to a cancer. Most of those variant of uncertain significance were downgraded, and instead of being called pathologic, now they're called benign. So just because somebody gets tested and they get one of these variant of uncertain significance, it doesn't necessarily mean that they will ever get the cancer. Conversely, though, anywhere between 8 to about 18% of patients, they got upgraded the VUS, so variants of uncertain significance, they upgraded them to a pathogenic mutation, which means that they fit into the category of true BRCA1 or BRCA2, so they have to deal with prophylaxis or treatment in that realm. So the point of this slide is that variant of uncertain significance should not be used to alter medical management. And in 2015 study, 50% of patients with a VUS or variants of uncertain significance not considered at increased risk for carrying a pathogenic or likely pathogenic variant underwent risk-reducing mastectomy. That means that a certain amount of women ended up having a mastectomy for no particular reason. Those variants of uncertain significance were never going to cause them to develop cancer. So this is something to consider nowadays because we can have a lot of direct-to-consumer testing, and that is something that will continue to grow, and I think it's an important aspect of our healthcare, but we just have to be a little bit careful of the results that we get. And with this, I'm going to end the show, and I understand that there might be some questions.
Thank you, Dr. Eftimie, for that insightful presentation. We do have a few questions. The first one is, how would getting genetic testing done impact my overall health?
So I think this is actually a very important question, because if somebody is known to be a carrier for a genetic mutation that eventually can lead to cancer, then certain things can and ought to be done. So for example, for a woman who is out of childbearing age and has a known BRCA1 or 2 mutation, but has never had any breast cancer in the past, she's faced with a choice. Should she actually get rid of all the tissue that eventually could lead to cancer, or should she actually have a very close follow-up? And some women opt to actually having a double mastectomy. So essentially you're taking about 98 and 99% of all breast tissue. So it decreases the chances significantly that one will actually get a breast cancer in the future. At the same time, they can choose to actually have both of their ovaries as well as fallopian tubes taken out, because that too will decrease the chance of an ovarian cancer. This is one way that this knowing whether one is BRCA1 or BRCA2 or even CHEK2 or PALB2 mutation, all of these mutations can definitely increase the risk of a new breast cancer in the future. It's a little bit more problematic, for example, with males who know that they have a mutation, for example, a BRCA2 mutation. As I have shown you on the slide earlier, they have almost a 7% chance of developing a prostate cancer in the future. But this is definitely a discussion that can be had with one's physicians. But right now, all of the data supports a prophylactic mastectomy in women who choose to do so for a breast cancer.
Thank you. We have another question. If I'm interested in moving forward with genetic testing, what steps do I need to take?
So first and foremost, the question has to be answered. Did somebody in the family have any cancer that can be related to breast cancer, or they've had breast cancer themselves? And like I was showing earlier in the slide, if a woman is under the age of 50 with breast cancer, she automatically should get tested for a BRCA1 or 2 mutation. But what about if a woman has never had a breast cancer in the past, but her first degree relative, for example, her sister and her mother both had breast cancer? In those cases, a genetic testing can be done. Ideally, though, the genetic testing should be done in the sister or the mother if they're still alive who had had the breast cancer, and if they are positive, then you, the patient, can also get tested. In the absence of that, you can actually be referred to a genetic counselor. We do have a genetic counselor over here, and they can go through the criteria whether somebody fulfills the criteria for genetic testing or not.
Thank you. I have one more question. Does having a genetic mutation mean that I will get cancer?
No. So like I was saying earlier, there are certain genetic mutations that are definitely inherited. So BRCA1 or BRCA2 mutation, that's an inherited mutation. But just like we saw on the slides, even if one has that mutation, only upwards of about 60 to 70% of patients will develop the cancer by the age of 50. That means that about 30 to 40% of patients will never develop the cancer, even though they do have the BRCA1 or 2 mutation. It's a little bit more problematic from an emotional and psychological point of view, because if you know that you have a mutation that potentially could lead to cancer, some people are very okay with not doing anything else besides just close monitoring and surveillance. Other people may feel very uncomfortable. And that is the reason that if you do know you have a mutation, you really should talk to the people who can actually guide you through it. And usually that would be a genetics counselor. If needed, that would be a general surgeon that deals with breast surgeries. It potentially could be an oncologist as well as your primary care physician. They can all advise what would be the best way of going forward with this.
This concludes our program. Thank you, Dr. Eftimie, for your informative and insightful presentation. And thank you, viewers, for tuning in. The entire broadcast of today's presentation will be available on our Facebook page and YouTube.